Hi everyone, my name is Arlie, and I am a doula practicum student at College of the Rockies in Cranbrook, BC. This is video number 5 in my 6-part video series on how a doula can help you have a better birth. So today we're going to be talking about medical interventions. I'm going to go over 7 different medical interventions that are commonly seen in hospitals where in Cranbrook, most people have their babies in a hospital. And so they may see one or more of these interventions. Now, sometimes these interventions are seen together, as I will go over, and sometimes you might see one, you might see none. But they are good to know, and they help to guide your making your birth plan, like we talked about in video number 3. And they also can help you just sort of educate yourself about what that intervention is and why it's even needed and the possible risks and benefits of it. And where it's applicable, I'll talk about how your doula can actually help you reduce the risks or even the chances of having that intervention. Okay? Before we get started, I just want to preface this video by saying that a lot of these interventions have a lot of weight to them, sort of emotional weight. They have, positive or negative tones. And so you hear that in the way that people talk about childbirth in general. And they might say, oh, you had a C-section, too bad. But if you think that it was a positive experience, that's really all that matters. If you're healthy and your baby is healthy, then, you are the only one who needs to put meaning to your birth experience and to any interventions that happened, whether they were medical or otherwise. And I just want to reiterate that before we get started. And I will practice some non-biased language throughout this video so that I do my best not to slant the conversation one way or the other. There is no harm and no shame in having these interventions, and you are just as strong to do them as to not. Okay? So, without further ado, we're going to start. I'm going to talk about first IVs or intravenous lines. So, IVs are a catheter that is inserted through your skin into your vein, commonly in your arm. You'll see arm, hand, or sometimes in this area, the inside of your elbow. It's called the antecubital fossa. And it is inserted into there, and it delivers fluid directly into your vascular system. So some people are hotly against IVs because they say, well, I don't want an IV. I don't want to have my fluid or my movement restricted. And I'll say, well, what do you mean? And they say, well, I don't want to be hooked up to fluid all the time. And I say, well, that's not necessarily, if you have an IV, it doesn't necessarily mean that you're going to have fluid running, which is a very common, I think, misconception that a lot of people have. So in BC, I don't know about other provinces, but in BC, we put in a saline lock for almost every patient that comes up. And it basically means it's that IV attached to a short piece of tubing that just has a little bit of saline in it, and it is capped. And it is there in case of emergency. It's there in case somebody needs antibiotics. Like if you have GBS, then you might need antibiotics, right? It's there in case of an emergency. If you are having a postpartum hemorrhage and you need blood, then they're going to give you that through an IV. If you're having extremely low blood pressure, they are going to give you fluids. They're going to want to give you fluids. You can take them orally, of course, like you can drink water, but the fastest way to bring your blood pressure up is with IV fluids. If somebody is having a seizure, whether or not they have a history of seizures or they have preeclampsia, and there's a risk of seizures, they're going to want that saline lock, that short little piece of tubing, as an insurance policy in case somebody has a seizure and they need to give Ativan IV, because it is the fastest way to deliver that medication for the best result, ultimately. So that's why IV lines are put in. It does not necessarily mean that you have anything running. Okay, so there are some risks to having an IV, admittedly. The first one is phlebitis, and this can happen, it's called phlebitis, it's inflammation of the vein. This can happen whether you have a saline lock or whether you have something running, like a fluid running. And you'll see that it's just sort of a red, streaky, warm line. It might hurt, it might feel uncomfortable, it's probably going to be warm because it's inflammation. And most commonly, phlebitis is caused by that catheter, that IV catheter in your vein is just, it's irritating the vein. It's moving around, it's irritating it. And any healthcare provider that you have is going to see that and say, let's take that out and resite it. And they'll put it in somewhere else, a new IV, obviously. And then they'll say, okay, here's a cold pack for that phlebitis, and just keep it elevated, and it will resolve on its own. So that's phlebitis. Another one might be infiltration, where fluid goes outside of the vein into the interstitial space or the non-vascular space. But again, your provider is going to see that. Then this is only if something is running. Okay, so if you have fluids running, then this might happen. And they'll see that and they'll say, oh, and they'll stop your IV and they'll put in an IV somewhere else. They'll take that old one out and you elevate your extremity and you're done. And it will resolve again on its own. All right, the third one, the third possible risk that I'm going to talk about with IVs today is fluid overload. And this one is sort of touted as very, very dangerous, and it is somewhat dangerous. It's touted as dangerous in a lot of natural childbirth books, that they say, well, if you have IV fluids, you might have IV fluid overload. And I think that is far less common today as it was 20 or 30 years ago, but it can still happen. And what happens is that your heart can't handle pumping that much fluid, and your veins all your vessels are full of fluid, and then it ends up backing up into your pulmonary circulation and leaking into your lungs. And you will notice, because you'll say, I'm having a really hard time breathing, or, oh man, I just really need to sit up. I feel like I can't catch my breath. And your healthcare team will notice. And they'll say, you've got fluids running. I'm going to have a listen to your lungs. They'll probably hear fluid in your lungs. They'll stop your IV and they'll go from there. Okay, so they know what they're doing. So have a little bit of faith in your medical team there. Okay, IVs are really common practice and they're pretty low risk. All right, next one we're going to talk about is epidurals. So with an epidural, there are a few things that you want to think about. First of all, an epidural is there for pain medication. And so think about your own experience with pain. Do you have a high pain tolerance, or are you thinking, no way am I going to go through that? I absolutely want an epidural because I know I'm not going to be able to handle that pain. Okay, that's fine. With that being said, I will tell you that generally speaking, the later you get the epidural in your labor, the more effective it's going to be, and the more effective your own labor is going to be. And what I mean by that is, with this epidural, it's a numbing agent that's put in. It's a local anesthetic put into your epidural space of your spinal cord. And so you'll be asked to kind of hunch forward, and the anesthetist will put a needle in between your vertebrae into your epidural space, and they'll insert, very much like the IV catheter, it'll be a little plastic catheter that just sits in your epidural space. And then medication is delivered through there, and it's commonly something like bupivacaine or lidocaine, sometimes with an opioid, sometimes not. Okay. And an epidural can actually be a really good thing because it can allow the mother to rest. It can allow them to relax because they can't feel the pain going on with their contractions. And one mother told me, the epidural allowed me to rest. It allowed me to sleep, and it allowed me to relax because I was so tense with all that pain that I knew that I wasn't going to be able to relax properly, to be able to dilate fully and push properly. So that epidural gave her that opportunity. She was able to rest, she was able to have a little nap, and she woke up and she was fully dilated, and then she was able to push, and she had a vaginal birth. So that is definitely an advantage of having an epidural. Now, that being said, because it's a numbing agent, you won't be able to move very much, right? You can't really support your own weight because you can't feel your legs. So shifting position is significantly more difficult. Being able to walk around and use gravity to your advantage to help get baby into the pelvic bowl to actually get them, descending the birth canal, pretty challenging because you can't move around. And there is this association between having an epidural and having an increase in oxytocin induction, because you're laying down, you're not able to move around, you're not able to use position shifts to your advantage, and so labor may slow right down. And so then your practitioner may say, I think we need to induce with oxytocin, we'll give you an oxytocin drip. And although you're not feeling those contractions, which, can be a good thing, right? Because those oxytocin contractions are quite strong. You are also potentially increasing the risk of having a cesarean section. So that's something to think about. Now, if you have a doula, you can have somebody on your team to keep you on track and say, okay, I know you want an epidural. We haven't tried these things yet, or maybe we should try this method again. Or, maybe we should go back to this other thing. Or I think there's one more thing that we can try before we do the epidural to help keep you on track, to help avoid that epidural if that's what you want to do. Okay, so the next thing we're going to talk about is induction. There are a few different ways you can be induced, but we are going to talk about 3 different methods here. Okay, the first method for induction is oxytocin. So this can be given IV. And oxytocin your body produces naturally, but this is just giving it a boost. It's giving you more oxytocin to further mimic the action of it, really. And what oxytocin does is it contracts your uterus to help push the baby down, to get, to push against your cervix to stimulate it to open, and then it helps push your baby into the birth canal, right, with those contractions. Now, that being said, IV oxytocin is a lot stronger. It gives your body a lot stronger contractions, stronger and longer than you would have if you didn't have oxytocin. And with that, there can be a lot more discomfort. These contractions are often described as painful by women who've had induction with oxytocin, and it can also decrease the chances of fetal distress only because as those contractions are pushing down for a longer period of time, there's the potential that your baby's head is actually pushing against the umbilical cord and blocking blood flow to its own body. So you're potentially increasing the risk of fetal distress with an oxytocin drip. Another way of inducing is with Cervidil or prostaglandins. Cervidil is the example that I'm going to use. Prostaglandins help to soften the cervix, and they help to dilate it fully so that your baby can pass through the cervix into the birth canal. The third thing that we're going to talk about for induction is an amniotomy. And an amniotomy is simply breaking your bag of waters for you. So that's what your provider will do. They use a very sterile instrument to break that amniotic sac, and it lets all the amniotic fluid out, brings the baby down into the pelvic bowl, and helps to induce labor because your baby's head is pushing on your cervix, and that's going to stimulate your uterus to contract and push the baby through the birth canal. Okay? With the amniotomy, it does help facilitate baby into the pelvic bowl. It does help to stimulate your cervix, but it increases your risk again of cord prolapse, because if baby's head is close to your cervix and then you remove all of the cushioning fluid, that head is going to be pressed right against the cervix. And if the umbilical cord is around there, it's going to be pushing on the umbilical cord too. So then they're not going to be able to have enough oxygen. So then you're probably, if you're doing heart rate monitoring, which you would be if you're being induced, you're going to see these heart rate decelerations. So the heart rate will slow down if the baby is pushing on the cord, on the umbilical cord. Okay, now something to keep in mind, all inductions are monitored. So, you are being induced and there is increased risk for fetal distress, but there's also increased monitoring. So it's not like your medical team is not looking, okay? Not watching at the same time. All right. So we talked about IVs, we talked about induction, we talked about epidurals. We are going to talk about extraction methods, a couple different extraction methods, forceps and vacuum. So forceps are still used today. They're used less commonly than vacuum extraction in general, depending on your facility, and check with your OBGYN and see what they do. And extraction is used if you're fully dilated but baby is not descending into the birth canal well. And so they might try to extract with a vacuum or with forceps. They might also, sometimes the forceps or the vacuum extractor are used to help turn the baby from posterior facing to anterior facing, so facing your belly instead of facing your back. But mostly it's to just pull baby into the birth canal so that there can be some progress with your labor. Okay, increased risks of extraction methods include possible chances of tearing. There is commonly episiotomies performed with forceps, somewhat common with vacuum extraction as well. potential for damage to baby, bruising, potentially cutting their scalp. You might also see in some cases a shoulder dystocia or a broken collarbone, depending on the position that your baby was in and depending on what was used. And there is, with vacuum extraction, a risk of cephalohematoma, which is basically a collection of blood, like a big old bruise on the baby's scalp, between the scalp and the skin. And this is relatively harmless because it's not as high risk as like having intracranial bleeding, but it is kind of a lump of a bruise that increases your baby's risk of having jaundice, but it doesn't necessarily, it will go away on its own. So it's not a long-term side effect. Okay, next we're going to talk about episiotomies. So a lot of people have talked about episiotomies, and I know for my parents and for a lot of people who had babies, around the same time I was born, said that episiotomies were quite common. Now, they were performed to increase the vaginal opening so that the baby's head would easily descend into the birth canal, or into the world, and be born. But because it was sort of believed that, if the baby's head gets stuck, then, they're at increased risk of fetal distress, and by having an episiotomy, we avoid that risk entirely. So now they're generally avoided. Ask your OBGYN or your practitioner what their rates of episiotomy are. If they do perform one, it is usually from the bottom of the vaginal opening to the anus, or in that direction. And as you can imagine, it does have some risks and some side effects that potentially go with it. So you're making a cut through muscle and skin and fat, so there is going to be blood loss. So there is increased blood loss. There is increased risk of damage to your pelvic floor because you are intentionally having those muscles damaged. So it's harder to heal those, and then it is harder for your pelvic floor to regain its strength afterwards. And then this can lead to urine incontinence and fecal incontinence. And it's just not the most comfortable thing in the world. The third risk of having an episiotomy that I'll talk about is a possibility of infection. And as you can imagine, it's a high possibility of infection because it is near two waste stations. Your urethra is right nearby, your anus is right there, and so it is really, really hard to keep clean. You can use things like sitz baths or peri bottles to help clean it, but it increases your postpartum pain quite a bit. So if you have a doula can help you try different positions if you haven't had an epidural. They can help you try different positions to use gravity to your advantage. They can help you push only when you have the urge to push, so you're working with your body's urges rather than just trying to push no matter what, which will increase your risk of, it increases your risk of having an episiotomy, and it also increases your risk of hemorrhoids because you're putting a lot of pressure on your pelvic floor and on those muscles. So doulas can also help educate you about different ways that you can do some vaginal stretching, particularly in the last 4 to 6 weeks of your pregnancy. You can use one finger or two, and this can also this can include your partner, which is very exciting, to insert fingers into the vagina and press down, so pressing towards your back, just gently stretching that vaginal opening so that your tissues are used to stretching. They're used to getting a little bit bigger. And one thing I wanted to mention about pushing with urge is that you're pushing bit by bit, and this is helping your vaginal opening open bit by bit. And so it's not going all at once, because that's not usually how it happens, right? It's going to happen in increments, and it gives your tissues a chance to kind of get used to being stretched and then going a little bit further. So another way that you can potentially enable your vagina to stretch a little bit more, your vaginal opening, is through visualization. We may have talked about this in a previous video about non-pharmacological pain management. We talked about, picturing an orange or a grapefruit, like a navel orange, like a big, big one, and picturing, that your vaginal opening is going to get as big as a grapefruit or as big as a cantaloupe, if that's what you want, so that your mind is actually working with your body to stretch your tissues. Okay, so that is what I have on episiotomies. Next we'll talk about fetal heart rate monitoring. So with fetal heart rate monitoring, we have internal and external. You may have fetal heart rate monitoring if your pregnancy is deemed high risk. So if you have high blood pressure, if you have preeclampsia, if you have a history of, let's say, gestational diabetes, or something similar, if you have a pre-existing health concern prior to your pregnancy, then the doctor or nurse, midwife, or whoever is involved, your clinician, may want some fetal heart rate monitoring. And so this can be done one of two ways. Generally, external fetal heart rate monitoring is more common, and it is less invasive. It does tend to limit your movements a little bit, because what it involves is it's actually two bands stretched across your belly. One of them is sort of positioned towards the top of your uterus, and it measures your uterine contractions, the strength of your uterine contractions. And the other sensor that is placed is further down, and it measures your baby's heart rate. And so it's really good to have, because it can tell your birthing team what's going on with your baby, especially if you're being induced. If you have an epidural, you'll probably have external fetal heart rate monitoring. The kind of downside to having it is that it restricts your movements a little bit more, because you're not able to, get up and walk around so much. It can mess up the reading a little bit. It's hard to walk around, especially if you've got, if it's wired to a big machine. It's not the easiest thing to move around with. So that's external fetal heart rate monitoring. And internal fetal heart rate monitoring is generally reserved for more higher risk pregnancies, or higher risk babies, or situations where the doctor may want more accurate readings. So it is more accurate because it involves having electrodes placed on the baby's scalp, which is, obviously goes up into your uterus, so there is an increased risk of infection that way. and it also decreases any chance that you have of getting up and moving around, because you can't move as long as you have an internal heart rate monitor. All right. There are various things that affect your fetal heart rate monitor and the accuracy of it. One could be the positioning of the mother. Another could be the position that the baby is in. Another thing could be if you have a lot of amniotic fluid, or if they're monitoring before your water's broken. If you have a lot of amniotic fluid, then those movements may not be picked up as clearly. And the last one that can limit the accuracy of the fetal heart rate monitor is if the mother is considered obese by the practitioner. So they may, those readings may not pick up as clearly in that case. Okay, to avoid fetal heart rate monitoring, you can do intermittent monitoring using a stethoscope and a handheld Doppler. That is a possibility. That being said, depending again on the complications and the severity or the risk of your pregnancy, you may want to opt for the internal or external monitoring. Just the continuous monitoring or intermittent, whatever your provider recommends. Okay, the last thing we're going to talk about is a C-section. So, well, some people plan C-sections nowadays, some people don't. You may want to plan a cesarean section if you have really, really high blood pressure, or if you have a breech birth where it's not a favorable breech position. There's a lot of different breech positions that your baby could be in, but if they're in what's called like a stargazer position where the chin is up, kind of like this, then that chin may actually sort of catch on the cervix and the uterine opening, and it can cause some damage to the spinal cord, right? Because that baby can't support its head at all. Now, there are some definite medical indications for a C-section, and they, in general, include if you have a placenta previa, where your placenta is in front of blocking the cervix, or if you have a placental abruption, where the placenta detaches prematurely from the uterine wall, and that is considered a medical emergency. You could have preeclampsia or eclampsia, as I mentioned, if you have like high blood pressure, or if you have risk of seizures, or if the doctor or your OBGYN nurse practitioner, whoever thinks you're at risk of having seizures, they may order a C-section for you. If due to some circumstance or one of the interventions that we talked about, there is a cord prolapse, then you may have a C-section. If there is concern that the fetus is in distress, so having a heart rate lower than 110 approximately, or if you have, now this one's not so much an emergency, but if you have low uterine fibroids that may be considered to block the cervix, then that could be indication for a C-section. There are a lot of indications. Some of them are more medical than others, and some of them are definitely more serious than others. If you have a C-section, it will be a lateral cut, so it'll go across your body. It won't go up and down, it'll be across like this, usually going in line with how your muscles grow. It is cutting through layers of fat and muscle, and several layers of tissue, so it does take a long time to heal. and there is an increased risk of infection just because it's a surgical incision. So it's a possibility that you could have an infection. And so you'd be wanting to watch out, for signs of infection. Now, if you do have a C-section, note that depending on the situation, your partner can go in, so your birthing partner, whoever that is, husband, boyfriend, wife, girlfriend, whoever, they usually can go in to the operating room with you. Sometimes they may not be allowed, and they might be allowed after the baby is born. But the rest of your birthing team, if you've got, your friend there, your sibling, your doula, they're not allowed to go in with you. Okay, generally speaking, in most of the facilities. So that is it. That was a very long video, I'm sorry. And I will see you next time in video number 6.